My name is Untitled Chapter. I'm an orthopaedic surgeon. I'm based at the Fortius Clinic. I'm a foot and ankle surgeon with an interest in joint instability. I'm going to talk about lateral ligament injury, so ankle sprains basically. I'm going to start with this guy, Pau Galano, who is an anatomist from, or was an anatomist from Barcelona. And most of the pictures you'll see later on are from his dissection. Okay, but also what I wanted to draw your attention really is to this statement about how anatomy really is the key to making a diagnosis, but also in treating those patients. And I think for me it's fundamental in treating lateral ligament injuries. The ATFL, it's quite a whimsical, small little structure. Okay, it's only about 1 millimetre or 2 thick, it's about 5 millimetres wide and about 2 centimetres long. It looks really insufficient. It doesn't look as if it would do a huge amount, as opposed to the calcaneofibular ligament, which is a tubular, thick, it's about the size of my finger in a grown adult. It's a big, thick structure. If you understand where they are, then you'll understand what they do during certain movements. So for example, the ATFL is actually very lax in ankle dorsiflexion. So when you're in that position, the ATFL is totally lax. Okay, so if you take a load when you're loading, you're unlikely to injure the ATFL, but you are likely to injure the syndesmosis or the CFL. On the other hand, in plantar flexion, it's tight. Okay, so plantar flexion loaded injuries tend to lead to ATFL tears and so forth. And you can see that quite clearly if we look at their roles in governing ankle stability. If you look at the coronal plane, which is side to side varus valgus, the CFL is king. It controls, and if you section it, then the talus will literally just twist inside the mortise. The ATFL, on the other hand, controls sagittal plane, so it's to and fro, and it basically controls the translation of the talus in and out of the ankle mortise, so that it subluxes out of the front. You all know the grading. I just mention it so that we all agree. Grade 1s basically are just those mild stretches, a bit of pain and palpation. The grade 2 are the difficult ones, the partial tear. I'm not sure what a partial tear is. And then the grade 3s are the complete ruptures, the blown up, big swollen ankles. And that's really what my talk is about. Okay, it's the more severe injuries. So, you know, why do people get sprains? I mean, in particular, why do professional athletes get sprains? Why do people, you know, why do these happen? Because we know when they happen, they take a player out for quite a long time. And we know there are risk factors. And the biggest risk factor is having had a previous sprain. Okay, so if you've had one sprain, you're likely to get another sprain later on. Which raises the question, are we maybe managing those sprains as well as we think we are? So what happens when you have a ligament sprain, you have an ATFL tear? What happens to your function? You know, what happens to your proprioception? Well, this is a really nice study from Australia, where they basically took high school athletes, which is what most of these are based on, and they picked all the ones that had an unstable anterior draw, so they examined the ankles, and they looked at their proprioception, they looked at their power, they looked at their ability to change direction, and they're all different compared to their non-affected side. Okay, so there is a residual weakness almost invariably. Even if the patient tells you they feel strong, if you actually quantitatively measure it, there seems to be a weakness in those groups. So that raises the question basically of how should we manage these? Now there's been endless randomized control studies and so forth, particularly over the last few years, looking into this as to, is there a difference between surgical management and just normal functional management of grade 3 injuries? And if you surgically manage them, and when we look at a re-injury rate as our outcome, it seems to be less in those that are operated on. Okay, so that's certainly what it seems to be suggesting. This is another study, this time from Japan, a randomized controlled trial, 2-year follow-up. And again, the recurrence rate seems to be slightly higher in the functional bracing compared to the surgical. But again, this is quite interesting. They kind of suggested that players get back a bit sooner if you operate on them compared to surgical, compared to conventional management. I think this systematic review in 2013, which was very comprehensive, really summarizes what we know so far quite well, in that for the grade 3 injuries, surgery seems to get people back playing a bit sooner. It seems to reduce the re-injury rate, and certainly subjectively the players, the athletes, seem to be saying the ankle is feeling better. But this is interesting. If you look at their overall advice to the general population, it's most ankle ligament sprains do well with functional bracing. Okay, so that's the overall review. Which kind of brings me on to Chris Hoy and the art of winning. Okay, because when we're dealing with professional football players and elite athletes, it is different to the general population, and I think we need a slightly different tact. This is how I make my decision. Examination, I think, is key. History comes a bit lower down, and actually imaging is way down the line when it comes to decision making on whether these are treated surgically or non-operatively. Okay? Let's talk a bit about examination. If somebody has an ankle that subluxes like that, the ATFL and probably the CFL has completely gone, okay, without a doubt. And that's a big factor for me in deciding what happens to this patient. And if you translate that to what you see in theatre, the talus just squelches out. I mean, you literally can totally sublux the talus quite easily. So if we go back to those two, this is what you find with a completely detached ATFL and CFL. So it's quite dramatic what you see there. What I do is, when I examine them, I compare to the opposite side. So most of you who've looked after most of the population always compare to the other side. Okay? So if somebody has a bit of an anterior draw on one side and a massive anterior draw on the other side, it's quite obvious. But likewise, if they have no anterior draw on one side and a little bit on the other side, it's also significant. So I think clinical examination is really important. History is also important, okay? Particularly within the context of a team. Often they've had a history of previous instability. As I said, they've often gone over a few times in the past. If there have been other players in the team who've had surgery, or maybe who've done really well from functional bracing, that player will have an opinion. It depends on where you are in the season as well. If you've got an academy player at the big end of the season, you know, you might be thinking about taking them through with functional bracing through the summer, see how you do, because you've got nothing to lose, you've got time on your hands. But if you've got the key player at the beginning of the season who wants to get back in 10 weeks' time with a certain degree, hopefully, that they'll get back with gusto, then I think that might influence you as well. So where they are in the team and the time makes a difference. The MRI, as I said, is low down my list of importance, mainly because I think there's a huge inter-observer variance in what's broken, what's not broken, what's a partial tear, what's a complete tear, what is pulled off the fibula, what isn't pulled off the fibula. You know, we're quite lucky at Forges, we've got great radiologists, but they'll often disagree. And then when we get scans coming from somewhere else, there'll be a disagreement, and the scan will vary depending on what day of the week has been done. There's a huge difference between them. But generally for me, if there's a multiple ligament injury, then that will influence me quite significantly. So in summary, when do I operate? It's highly unstable ankles to clinical examination. It's what the patient wants, it's what the club wants to a certain extent, it's where they are in the season. If they've got 2 ligament injuries at least on MRI, that will also influence my decision. I'm not going to talk about this, I think you all know about it. It's a Broston-Gould procedure. It's basically involves directly repairing. So this is the ATFL, it's the tear in the capsule, and all you do is stitch this back together again. The CFL is often pulled off the fibula, it sort of flops out of the wound, and again it's simply reattached. And again, it's a very straightforward anatomical reconstruction. It simply repairs what's been damaged. I think the rehab is important. I think it needs to be aggressive. I think it needs to be functional. I think it needs to be loaded from very earlier on. So they're going to a cast for 2 weeks. At 2 weeks we start physio in a boot where we work on dorsiflexion, we work on perineal function. At week 4 they go into an A60 brace and we progress on from there. So, how are we doing at Fortius? Are we any good at doing this? This is what I've talked about. Does it make any difference? Well, This was up till 2014. This was 22 isolated ATFL, CFL injuries. Since then, I think I've added another 10 to this, and I think James has probably added another 20 to them, I would imagine. So the numbers are quite a bit higher. They were all treated with surgery, so these were all grade 3 lesions. They were all treated with surgery. They returned to play typically at 10 weeks. Okay, so this is return to play. This is not return to training. It's return to play. So it fits in with what the literature suggests. They seem to be returning slightly quicker. At 2 years, we had no recurrence, which again is in keeping with the research, with the papers. They seem to have a lower recurrence rate with that. So, in summary, I think you have to assess each one individually. I think really unstable ankles, I think we fix them. It gives a certain degree of guarantee that that ankle will be stable at the end of their 3-month rehab process. It seems to have a very low complication rate from our series at least.